So I'm going to actually talk about chronic non-malignant pain and opioid abuse and misuse. And before I start, I just want to let you know a little bit about my experience with this. So after I graduated from residency, I went and worked in Central Appalachia in Eastern Tennessee for 10 years. And that area actually had a problem with opioid abuse, which actually preceded the rest of the country by about 10 years. And so the other areas of the country were like out in the Northwest and things like that. And so our clinic at Dayspring had to really develop a lot of protocols, and we had some working groups and things that worked with this issue. And then subsequently, in 2012, I went to work in a residency, and so I thought that I would come to residency and maybe have some things to offer. I did not realize it would be in this particular area. But the experience actually working in an underserved community and dealing with opioid abuse was really invaluable, because actually that's a problem that everybody faces now, and especially in the residency program. And the reason is because residents turn over every few years and they're inexperienced. And so it's even more important that they have protocols in place. So we ended up devising a whole bunch more protocol, and I was able to do QI projects in the background and do research in our medical library and things to kind of make it more robust than we had done at Dayspring. And since then, I've been able to kind of roll some ideas out to all of the practices in our health system. So this is not a drug company lecture at all. I just want to make that real clear. There are different ways to manage chronic pain, and I'm taking a different plan completely from what you would get at, say, a medical conference. A lot of the information I have is from the University of Washington, and I actually have their recent upgrade, which just came out in June. And I also have our protocol that we use in the residency, although I will say that it's a constant learning process, so if you guys want to look at it, I'm not actually going to go into so much about an actual specific protocol, but talk more about theories and how to design one, basically, if that makes sense. And there is a QI project at the end of the presentation, so we end at 8:30, is that right? So if I get done with the main body of the presentation before then, I will present the QI project, which actually is probably we probably won't have time to do that though. So I wanted to start with the Bible first. This is Psalm 34, 1-3. I will extol the Lord at all times. His praise will always be on my lips. I will glory in the Lord. Let the afflicted hear and rejoice. Glorify the Lord with me. Let us exalt his name together. Really, if you think about chronic pain and addiction, this is really our modern day leprosy. And so when you see these patients in your office, maybe I shouldn't say you, when I see these patients in the office, sometimes I just want to groan. But when you read a Bible passage like this, which talks about how, let the afflicted hear and rejoice, glorify the Lord with me, let us exalt his name together. I really see this as, an example of how we need to come together with these people that are really hurting. And I really feel that if you can actually, in a clinic setting, do well with chronic pain or addiction, this is a chronic disease which is really a litmus test for how you care for your other chronic diseases. So it's a good example, really, of how to make an impact, say, for diabetes or for something else. And it's very important to be very competent with this. And so we'll look at it from the AAA perspective, talk about why there's a problem, and then a model for addressing it, and then I'm going to probably drop off the QI example at the end. So probably most of you are familiar with the AAA from the Institute for Healthcare Improvement, and it talks about improved patient experience, reduced cost, and improved population health. And it's actually a really nice model for looking at this particular problem. So according to research, about half of patients with chronic non-malignant pain will switch providers in search of relief. And the main reason for this is not doctor shopping, it's rather the way that they perceive the doctor's knowledge and attitude about treating their pain. And what's also really important with this is that satisfaction did not come from providing a narcotic. And there's numerous articles that have shown this, also in the ER world as well as in primary care. And that's really important because we're being scored now on our patient satisfaction. And you may have a hesitancy not to prescribe the narcotic because you're afraid about what the patient will do. But really, research has shown that a full explanation of the patient's condition, perceived merits of the treatment recommendation, and then the better the patient's self-pain problem is explained, the more they agree with the treatment recommendation. So appropriate treatment also involves a caring provider-patient relationship, communication of realistic treatment goals, and patients having trust and confidence in their providers. And one way to do this is to actually set up a protocol and have discussions and have providers be on the same page so that you can actually work together and patients then will really understand what you guys are doing in regards to this. So ultimately, the best way to improve health is actually to lower death rates. And the next slide will kind of go over that, but the big normalization of opioid use for chronic pain within primary care has really seeded our heroin epidemic and addiction. And this particular addiction doctor, Dr. Michael Seisser, actually, he's done a lot of formal surveys of people as they end treatment, and basically, unfortunately, a lot of them have gotten their opioids from primary care. But the question is, if we change our prescribing practices, will fatalities decrease? And there was really the first state that really did a lot of work with this was the state of Washington. And they found that in 2007, when they put in prescribing guidelines, we subsequently were able to reduce the number of opioid-related deaths by 50%. And it was actually really a very short amount of time, so it made a huge impact. In regards to cost of care, chronic non-malignant pain is an extreme amount of money spent in the U.S. and that 560 to 635 billion. The cost of opioid abuse in our society is about $56 billion a year. And as far as the difference in actual expenses for patients that are abusers versus non-abusers, if you're looking at reducing costs, it's also significant. So 15 to 18,000 per year. This is actually based on insurance claims among abusers, and 1,800 to 2,200 among a matched comparison group of non-abusers. And you can see that a lot of things on hospital inpatient care, but then also physician visits. So there's 4 misconceptions I'm going to go over, and I think this is really important as you look at, how do you get this issue under control, say, in your community. And the 4th misconception is one that I'm actually hoping to publish and do a little bit more research into. But the first 3 have come from a number of sources. And the misconception number 1 here is just that medical providers have an ethical responsibility to eradicate chronic non-malignant pain with opioids. Really, the keywords here are with opioids and eradicate. The Institute of Medicine, as late as 2011, Leaving Pain America, had stated prevalent pain is considered undertreated pain. And how this ethical argument developed is basically, over centuries, nobody would argue that physicians and the medical profession have at its core doctrine the relief of pain and suffering. And subsequently in the 70s and 80s, this really focused in on hospice and palliative care. And then in the 80s and 90s, it went to, cancer pain. And in the 90s, when I was in medical school, it was a big focus on acute pain, and actually pain as the 5th vital sign came out in the 90s. Subsequently in the 90s to 2000s, it extended to chronic non-cancer pain. And really, above the red dotted line here, I would say that the ethical argument held up. And it's really below the line. And the reason is because, as we'll see in the next misconceptions here, that the evidence that supports the use of opioids for chronic pain is just not there. And what happened, and this is the industry response, and it's interesting, I have a med student with me right now, and she is our PMP state representative from her med school, and the Pennsylvania Academy of Family Physicians just had a CMC last week on treating chronic pain, and they actually had a drug-sponsored physician there, and he gave the classic, line, like basically stepping up therapy and things like that. And really, this is what happens. So OxyContin was marketed in 1996. It was supposed to have a low risk of addiction, and you can just see how, this is actually 6 synthetic medications or opioids, but it just escalated from, the late 90s. And hydrocodone is the #1 prescribed medication. U.S. comprises 5% of the world's population, but uses about 80% of the world's opioid supply. And so, how many of you have ever heard of Ivan Illich? He's a philosopher. Yeah, a couple of you. He wrote a really good book. It's called Medical Nemesis. But the belief that chronic non-malignant pain relief can be achieved with opioids has caused broad iatrogenic harm. He actually breaks it into 3 areas. Clinically, you see that in overdose, abuse, and adverse effects in patients. Socially, you see it in escalating opioid diversion, abuse and overdose. And the time he wrote this, it was in adolescents and poor, rural, middle-aged adults. Now it's really everywhere. And then culturally, we really have an erosion of our ability to manage pain in non-medical ways, and also unrealistic expectations of relief. And that kind of leads us then to the second misconception. So maybe there is a partial ethical argument, that's probably a little debatable, but are they effective in relieving pain and improving function for chronic non-malignant pain? And, for the other argument, or the other misconception, I tried to have one slide that supported the frame of reference of that misconception, but this is really not possible. There are multiple articles now that talk about this, and it's really not supported by the medical literature. So what happens is that there's multiple systematic reviews of randomized controlled trials. They show a short-term benefit of opioids for chronic pain, but then after about 16 to 20 weeks, that benefit goes away, and actually the reverse happens. And there's no proven relationship between pain relief and improved function. In other words, if you titrate up somebody's narcotic to relieve their pain, you actually see a decrease in their function. And there's a Danish study that's often quoted, and this is actually was done. It was about 10,000 individuals. They divided it into patients that were having pain, those that were not, and then those that were having pain into those that received opioids and those that did not. And it was really an epidemiologic study looking at function, and they found that opioid usage was associated with not being physically active in leisure time, not being engaged in employment, and being on disability. And for those patients that received opioids, 90% of the opioid treated group reported pain being uncontrolled versus 46% in the non-opioid treated pain group. And this, I have this study, I can give you a copy of it, but it's often quoted in guidelines. And they concluded that it may be hypothesized that opioids could have relatively short-run benefits, which in the long run may turn into opposite and negative effects. I can't really say that word in the morning. As previously described by an author as the opioid downhill spiral. And if you look back in medical literature, this goes back to like the 1870s when it was first identified. So then the third misconception is that opioids are a safe alternative for the treatment of chronic non-malignant pain. And when I was in medical school in 1996, there was a consensus statement released which actually said that de novo addiction was low to opioids, respiratory depression was short-lived, tolerance was not a common problem, and also efforts to control diversion should not constrain opioid prescribing. And we know now that this is false. One author has mentioned that the U.S. has conducted an experimental population-wide treatment of chronic pain with long-term opioid therapy. The benefits have been hard to demonstrate, but the harms are now well demonstrated. And there have been a lot of studies that are trying to look at the benefits, and they just can't get them. I do have another slide, which I didn't put in here, which would have been pretty boring for you, but it looks at a series of randomized controlled trials for low back pain, and regrettably, 4 out of 6 of those actually were sponsored by drug companies, and the one that was not, or the one of the two that were not, actually the placebo drug was donated from the drug company, and they actually do enhanced trials, which means they actually give somebody the opioid to see if they have a response, and then actually randomize them into the trial. So it's kind of interesting how a lot of these studies are actually done. But basically, we've had an acceleration then in our prescribing of opioids since the 90s, and striking increase in overdoses and hospital admissions. So the true incidence, now in DSM-5, they talk about the opioid use disorder, which is what we used to talk about with withdrawal, tolerance, and addiction and dependence. But the true incidence is really unknown, but it's probably about 10 times what's predicted. 1 week's supply, or more than or equal to 2 prescriptions for an acute back sprain, doubles the risk for long-term disability. Use of opioids for more than 90 days, and I have another slide which I'll go over this later, but leads to 60% more likely to still be on chronic opioids in 5 years. This really takes us then to the 4th misconception, and that's that acute and chronic non-malignant pain are distinct and unrelated. And I think I'm a family physician. I always look at prevention, and that's kind of where I'm going to be going with this here. So acute pain, probably all of you would have a definition for this, but basically you could say it's the normal predicted physiologic response to anything that causes tissue injury. And whereas chronic pain really has a little bit of an ambiguous definition. It's either pain that lasts 3 months or pain beyond the normal course or the normal time for tissue healing. And there's been a lot of debate over these definitions. But this is actually from an article in Lancet from 1999. But one of the things that happens, and what has been shown, is this is the busiest slide. It might be the second busiest slide that's in here, so you don't need to worry about most of this. But basically, some of the neuropsychological responses that occur from pain actually, and that lead to chronic pain, actually start within just a few minutes of the painful event. And so a lot of people think that you don't need to start worrying about chronic pain until maybe that 3 months, or maybe you're treating the acute pain and they're beyond the point where you'd expect it to be persistently hurting for them. And basically, unfortunately, those changes that lead to chronic pain have been clearly shown, which means that we should actually really be thinking about it right from the start. So, and that leads me to the question, is it time to consider a relationship of acute and chronic pain? And the way I'd like to think about this is to think about other chronic diseases, and one of those being diabetes. And in 2002, the American Diabetic Association introduced prediabetes, and that includes insulin resistance and glucose intolerance. And if you've ever been in the room with a patient and they have, I don't know if you remember this or not, I don't know how long you have been practicing. I know I look really young, but basically, if you said to a patient, you have insulin resistance, my response, and what I've seen patients responding with, is if they feel like they're having a hypoglycemic episode, they'll just eat more sugar. And regrettably, they would not focus on, exercise, diet, and things like that to prevent those hypoglycemic episodes. And when you tell somebody they have prediabetes, it really changes the discussion. And what I'm proposing, and what I think really is supported by the literature, is that we kind of think of acute pain as pre-chronic pain in a way, which means that we immediately start thinking about how to prevent a person from getting chronic pain when they have their acute pain episode. And you could include acute pain, post-procedural pain, neuropathic pain, inflammatory pain, whatever you would like, as far as that would fall into what would be more acute. And this is really, if you don't mind, I'm going to shut the door here a little bit better. Probably won't work, but that's all right. Anyway, so this is a chronic, have you heard of, I'm sure, chronic disease management, and it's really an organized approach to approaching chronic diseases, which actually can involve things within your health center and outside your health center. I'm actually looking at this more from the perspective of, a health system, within, say, like Lawndale or within the residency program. But it involves an element of prevention, and there are things that you can do for diabetes and for, say, chronic pain. There's an element of screening, and within that screening would involve screening for depression, certainly with any chronic disease. Chronic pain, screening for, say, post-traumatic stress disorder or something like that. There's a multi-dimensional treatment approach, looking always for complications, especially with diabetes. Self-management goal setting. You're always doing some sort of evaluation and reevaluation. There's certainly a team approach, and the team approach with chronic pain would really involve, say, a nurse or some administrator within your office, maybe helping the provider in the background to make sure that the protocol is being followed for your patient. Group visits, and there are places that are doing group visits for chronic pain. Now, we could not do these in Jellicoe, where I worked in Tennessee, because it was a small town. We were afraid if everybody got in the same room and had narcotics, that then people would have their houses broken into, so we never did these. But there is another CCHF member who works in Albany who has really successfully done these. There's always patient-provider engagement, referrals. We actually have an osteopathic manipulative treatment clinic within our residency, and we refer a lot of people there. They get good response, special referral, and then registries and monitoring. And you can actually do a QI project on any of these issues within your health center. We've done some of the self-management goal setting, and I actually included an action plan in there for you. So as far as the diabetic example, say you have a 55-year-old newly diagnosed and they have elevated blood sugars, and don't raise your hand, but how many of you would actually just start them, say, on a medication? If that doesn't work, go up or add on a second medication. If that doesn't work, go up to a third. Nobody would do that. Actually, our treatment for diabetes, and this is probably the most complex slide, and it's really intended to be, it involves many things. You're screening for, pre-diabetes, you're looking at lifestyle modification, family history, all kinds of things. And regrettably, what we've done with chronic pain is actually used a stepwise approach and not actually incorporated, many more things in with our treatment. And this is still recommended, from different organizations. But what happens with, chronic and acute pain when you do a stepwise approach really is you get increased, sales of narcotics, and you get opioid deaths going up and admissions going up. So you look at chronic pain treatment over time. You have day 0 of, say, when you would start a prescription, 90 days, and that may be the time that, say, you would say that person is now in chronic pain, and then you have years out here. This would be about 1 month and 2 months. Basically, you probably see 3 types of patients in your office. There are those patients that you've been treating for chronic pain for many years, and you actually have them on a narcotic, and you've been following what you thought was the appropriate guideline, which it may be. There's other people that you've treated for acute pain, and they've gotten up to 90 days. Now you're thinking, well, do they have chronic pain? Because they're not doing any better. And then where I worked before, there's the patients that you inherit that are on these, and there's a lot of them out there. And, what do you do with those people? But basically, if, say, you're looking at that middle group, the acute pain, you initiate an opioid, you see them back for reevaluation right in here. And by the time you see them back at, say, 30 to 60 days, they've already started to develop some tolerance to the medication. And, a certain percentage will stop taking opioids during this time. About 1/4 of them will stop because they have a side effect, and about 10% because they feel like it's not working. But if they make it to 90 days and they're still on that narcotic, more than 50% will remain on the opioids for years later. And this is a well-done study that looked at this, and it's been quoted a number of places now. So really, with this in mind, it's so important right back here before you initiate that you make sure that person's appropriate. And who continues, after 90 days, it's really called adverse selection. It's not a very original name, perhaps, but it describes the process where the likelihood of a patient receiving an opioid treatment regimen increases as the associated risks increase. And this may surprise you a little bit. Maybe some of you have read this information, but history of depression or other common mental health disorder increases the likelihood of long-term opioids 3 to 4-fold. History of alcoholism or non-opioid drug use increases the likelihood 4 to 5 times. And history of opioid abuse or dependence increases the likelihood 5 to 10 times. And then there's a triple thread that the higher your risk, the more likely to receive all three, which is a high opioid dose, higher DEA scheduled drugs, and concurrent sedative hypnotics like, say, a benzodiazepine or something like that. And I'm assuming you all know what DEA scheduled drugs are. Am I talking at the right level? Okay. So a better way probably to look at this is, you have acute pain here up to 90 days. And I'll tell you, that slide 2 slides ago, we developed about 2 years ago. And my partner is actually my boss, but he's an addiction specialist. We really struggle with that. How do you advise people? And we've kind of developed this over the last year. But basically, you have somebody who presents with acute pain, it gets better. So, they really don't have chronic pain. It's really ideal. What often happens, though, is that they'll kind of get better and then they get a little worse. And you find out it's persisting longer than you would expect. Or what I would see a lot down in Appalachia, where there was a lot of really difficult manual labor jobs, is that somebody would injure their back, would kind of get better, then would get worse, it would get better. You never know, is it acute or chronic? But I'm advocating that you think of when patients present with an acute pain episode, that you really think of it in a continuum. If you want to call it pre-chronic pain, that's fine. And you consider primary and secondary prevention. And so primary would be that you're trying to prevent pain before it even happens. And I have a slide that will show some ideas for that. Secondary would be the person has pain, you're trying to prevent the chronic disease, which is chronic pain. And then there's tertiary prevention, if you really want to know this, where they have the chronic disease, but you're trying to prevent complications, like depression. So the prevention of a chronic pain should be viewed the same as the prevention of other chronic diseases, such as diabetes, cancer, stroke, and coronary disease. And there's a lot of politics in how many people have chronic pain. I was trying to figure out the actual numbers. I didn't realize how political it is, but basically, Institute of Medicine says that diabetes, cancer, stroke, and coronary disease is about 63 million people, and chronic pain is about 100 million. So you can see that's many more than those 4 main diseases. And in regards to primary prevention, this is really what we're doing in our offices when we do a complete physical. We're talking about anticipatory guidance. It's injury prevention. You're recommending seatbelt use, headrests, airbags, helmets, safe lifting habits, and really in the work environment, if somebody injures their lower back, it has a very high risk of going into chronic pain, and so it's very important that you actually have people lifting appropriately. For elderly adults, offering the shingles vaccine is very important, because if they get shingles, they have about a 25% chance of going into post-traumatic neuralgia. Certainly, having people avoid alcohol, drugs, tobacco, and then emphasizing healthy lifestyle. And however you can do that, and we know you guys probably have a lot of different things that you're doing already, but recommending daily exercise, stress reduction, weight control. I don't want to bore you with rat studies, but there is an interesting rat study about daily exercise. So there are some practical human studies that show that people that exercise have lower risk of chronic pain. And they never really understood why that is because they can't really dissect the person. But they had rats that they put in a cage with a wheel and made them run for 2 hours a day, and those that did not have something to exercise, and they found that if they had the rat exercise for 2 hours a day and then they induced some sort of injury that would cause chronic pain, they dissected them. And actually there was a blockade of the new receptor that occurs from exercise, and the benefit of the exercise lasts about 1.5 weeks. So clearly showing that there is a cellular reason why people that exercise regularly actually have less chronic pain. And then certainly mental health care and treatment, preemptive analgesia for surgeries. What's interesting with this, preemptive means you receive pain control before you have the pain from the surgery itself. And there was a study done where they actually did, they gave people gabapentin just for a few days before routine surgery. They actually gave them, they put lidocaine locally, and then general anesthesia, and they gave gabapentin after the surgery, and those that got the gabapentin actually required no narcotics. It was a very striking, response. And there's a lot of research that could be done on that. The problem is that we just actually don't, practically speaking, there's not a lot of knowledge out there about this right now. And then secondary prevention, somebody has an injury, making sure they stay active, certainly not so that they injure themselves again, but just so that they do not allow it to lead to some sort of inactivity. It's very important to identify goals and address barriers to succeeding. And this is when somebody has an acute injury. And the reason being that there may be something there that's preventing them, with anxiety and fear from doing the activities they want. And especially if somebody is in, a major motor vehicle accident, they may have post-traumatic stress disorder or something like that, which would lead to them having, issues about return to their normal activities. Surgical techniques, which I won't go into, treating psychiatric disease, treating substance abuse disorders, and then avoiding opioids except for post-surgery when pain is severe or when other alternatives are ineffective. Now, as far as pain scoring, this can be very subjective and very difficult. And, my patients in Appalachia, everybody said they had it on a scale of 1 to 10, they had a 15. What do you do with that? Well, you do the best you can. This is actually from the guideline from, the University of Washington. And I don't know what to say about that, really. I think people that have a 10 score on the pain scale should have elevated blood pressure and elevated pulse and really look like they're in pain. So treatment of early pre-chronic pain, this would be early acute pain, really from 0 to 6 weeks after injury or surgery. Emphasis on self-care. We really have to encourage them to be active and continue doing things that they enjoy as much as possible. You really want to make sure that you're being supportive of the patient. And kind of a shift is, it used to be that we emphasized pain scales. It's really, we should be emphasizing functioning. And, the problem with the pain scale is that if you actually titrate medications based on a pain scale, it doesn't work. You need to make sure the person is able to do the things that they want to. And it's also very important to differentiate the difference between short-term relief, which an opioid will help with, versus long-term, where it will not. So now if we're looking at it with opioids, again, opioids should be reserved for right after surgery, because there are studies that show if you treat pain better right after surgery, the person has less risk of chronic pain. For the most severe pain or when other things are ineffective. And I know you guys have dental associated with your health centers, I believe. It's very important to limit for dental pain the use of opioids for complex dental procedures and really limit them for the shortest amount of time and the lowest dose. Evidence does not support the use of opioids as initial treatment for back strains or other strains. And if they are prescribed, use should be limited to short-term, less than 14 days. And pain and function should improve during this time. And most people would view as about 30% improvement actually in pain and function to say that you're seeing improvement. Now, if you're the person though that is in pain, 30% may not be good enough for you, but that's what's really a realistic expectation. And taper them off the opioids by 6 weeks. And then between 6 and 12 weeks, this is really where you want to get your screens involved, looking for why the person may still be persisting in pain. So as an example, well, before I go into that, it's also very important, and there's an acronym associated with this, CMI, clinically meaningful improvement. You want to show that in your chart, the person is having clinically meaningful improvement in function and pain with the acute use of opioids. You want to screen patients for depression starting about 6 to 12 weeks after the injury, and or PTSD. And one of the often overlooked areas where you may need to screen for PTSD are people that are admitted to the ICU. So whether it's a medical or surgical ICU, it's very traumatic, and we often forget that. But there's a high risk of getting chronic pain after an ICU stay. And screen for opioid risk, and there are some different ways of doing this. It's beyond what we're here to talk about, but a psychological interview is the best way to screen for opioid risk, and that's considered the gold standard. If you compare sensitivity and specificity to the psychological interview, the SOFAR is probably your next best thing, which is a 17-question screening. However, it's a little bit more than what we can do sometimes in our office. The opioid risk tool is very short, very quick. It's pretty good as well. And then it's recommended that if you're still having somebody on opioids at 6 to 12 weeks, that you do a urine drug screen or some other screen like ESPER, which I'll assume that you guys know about, in order to see if they're actually using opioids right now or alcohol abuse, abusing opioids or alcohol. And if you do find a red flag, then you stop the prescription. Re-examine them, consider discontinue or tapering if they're on a sedative, whether that's something for sleep or a benzodiazepine. And then finally, if they do not have this clinically significant improvement or clinically meaningful improvement in function, if they have adverse outcomes, current substance abuse is identified, or a history of opioid use disorder, you wean them off the opioids and do not restart them. So the last thing I want to do is just shift in looking at protocols for chronic pain. Now, this that I'm presenting today is actually associated with another whole hour-long lecture on actually a chronic pain protocol that we developed in a residency. I'm not going to go into that, but I'm just going to touch on it briefly. And how much time do I have left? So I have just a few minutes. This will be about right. So here's what we would call the old model. All the physicians do something a little bit different. These 3 R's are where you see a new patient, refer them. You say, well, maybe there's some hope that you can get some treatment here, and they get rejected. It doesn't work. You get this idea of an enmeshment, and what's meant by that is a patient will identify a provider that has given them a narcotic for their treatment of their pain, and they will see no other provider, and that provider always feels like that patient is pushing their limits, and it becomes very frustrating and leads to physician burnout, really overall poor treatment of pain, and increasing prescription medication abuse. Well, there's always new models, and I'm not saying that patient-centered medical home is the best model, but it's the model we have right now. And this is really where there's a team approach. It's patient-centered. You have protocols in the background, which means that when you're in the office or in the exam room with a patient, you're not debating with them, and it's not a negotiation. This is what our protocol is, and this is what we can do for you, and you talk about that right up front. You have clear expectations. You monitor outcomes and do quality improvement projects if you're able to in the background, and hopefully your electronic health record enables you to actually have flow sheets and things which help with this. So you'd have, with this new model, a unified approach among providers. You have standardized protocol-assisted flow sheets. It's a little debatable what controlled substance agreements should be called, because they're really an informed consent. They really don't have much more than that, but it's really a way of sitting down with the patient saying, this is what I expect, and this is what I will provide for you. And just so that everybody's on the same page and you actually sign a form. You also if you have teams of, say, physicians and mid-levels, there's definitely a place with chronic pain for that team approach, also with the nurse as well, because the physician provider does not need to see the patient all the time. You can actually designate people, it would have to be a special person, but you can designate somebody in the background to be assisting with this monitoring so that it's not all on the shoulders of the physician or the primary provider of that patient. And then certainly there would be periodic reassessment and again the quality improvement. So this is our protocol in the residency, and so that you can read this a little bit better, I printed a couple slides out from that other lecture, and it's in your handout. And you know, the idea is that you assess the patient, looking for, you know, this is for people with chronic pain. You know, looking for, are they appropriate for, you know, different types of treatment? What is their risk based on their chronic medical issues? You're doing screenings like you would do between the 6 and 12-week period, and then you're treating them. And the next slide in this lecture here, I'll go through that. And then you're actually, you know, reassessing them. And part of that is to do some sort of validated screen for function and pain level. You're doing adherence monitoring, which, you know, can involve urine drug screening, pill counts, you know, maybe, you know, frequent visits, assessing for side effects, and constipation being the most common side effect. And then, you know, basically, hopefully you have a protocol as well for what do you do for the patients that fail. And I, as somebody who really is interested in community health, feel that it's not always the right thing just to fire those patients from our practice, because you're really putting them on somebody else then. But making sure that you wean them down. If you identify that they have an addiction issue, getting them into treatment. And then for our treatment overview, you know, this is actually from Dr. Berland, who is actually from the University of Michigan, I think. But anyway, we took this and kind of adapted it for our setting, but basically there's a whole sequence, and it's where you establish treatment goals right up front. You identify and treat local pain generators. Say that their chronic pain is coming from their knee and they could have a joint replacement, then certainly you want to offer that to them if needed. Promote healthy behaviors, like so. You don't want to provide opioids to somebody who's normally obese and is not interested in losing weight or exercising, because you're just going to exacerbate their problem, which may be, you know, sleep apnea. And that does go to the restore sleep. So you want to actually work with somebody to restore their sleep, because that may be the cause of their chronic pain if they're not sleeping well. And then start adjuvant pain medications, which would be like gabapentin or amitriptyline. Definitely treat comorbid psychiatric conditions, because you know, there are people that are appropriately treated with narcotics for chronic pain, and there is definitely a subgroup of that. And there's people over here that are definitely addicted, and then there's this middle group that are the chemical copers, they call them, which are people that are using their narcotic to deal with their daily stress. And you definitely want to screen out that person before you go to this step over here of initiating opioids. And I don't know, time-wise, I don't want to go past the time.
We have a few more minutes.
Okay. So this is actually, this slide here is a global view of, you know, one way to look at this within your community. I'm not going to, again, go into the QI project at the end, but what I really focus on and teaching about is, within the residency, is this clinical encounter. I have a partner that's really, you know, a specialist in addiction. He does those lectures. But basically, there has to be a balanced approach. So if you guys are interested in, you know, developing policies, you really should, as a community health center, engage your local community and health system. And the reason for that is that, in speaking with some other addiction specialists, if you decrease the amount of narcotics that you use in your office, there's going to be a spike of heroin abuse in the community, and it takes about 3 to 5 years to get that out of the community. So it's really important that it's a balanced approach to this. And you know, it starts with your practice, mission, and vision development. For example, if you are are a free clinic, it probably is better not to prescribe narcotics at all, because you're going to be inundated with patients that are trying to get that. Where I worked at Dayspring, we actually had new patient screening that we did, so we did not want people to be doctor shopping, and so we would tell them, number one, we would not prescribe control medications at the first visit. We told them when they called for the appointment that was the case, and we also we would not see people that were just coming because they were fired because of inappropriate prescription somewhere else. I would also advise, policies and protocols for chronic pain as a practice-wide, and then, again, this was the QI project I was going to talk to you about. Health system, I won't go into that, but local community, it's really important to have the providers on board that are outside of your practice as much as possible, and then you get, if possible, political and judicial involvement, maybe addiction services, community education. And then in the clinical encounter, the appropriate treatment of acute pain, certainly having the screens available that you need to screen the people for the appropriateness and doing the right documentation. In regards to the patient, again, the new patient education and screening, setting up expectations, self-management goal setting, which is very important, and could actually be a whole separate lecture on itself, so, which I won't go into, and then controlled substance agreements. And for the clinician, the most important thing is really compassionate care. I think that this is our way of really sharing the love of Christ with our patients. And again, these are our patients that are really hurting, and this is our modern day leprosy, I think. But at Dayspring, where I worked, we actually had it so that providers did not, we requested that providers would not prescribe narcotics to control for chronic pain in the first 6 months of practice. And we did that to protect them, and all of them really appreciated it, and that is something that you could consider. And the reason is because so many providers would come and they would just be inundated with people trying them out, and we wanted to protect them from that. And then developing, policies and protocols and practice, primary and secondary prevention. So I'll stop with that. All the physicians do something a little bit different. These 3 R's are where you see a new patient, refer them. You say, well, maybe there's some hope that you can get some treatment here, and they get rejected. It doesn't work. You get this idea of an enmeshment, and what's meant by that is a patient will identify a provider that has given them a narcotic for their treatment of their pain, and they will see no other provider, and that provider always feels like that patient is pushing their limits, and it becomes very frustrating and leads to physician burnout, really overall poor treatment of pain, and increasing prescription medication abuse. Well, there's always new models, and I'm not saying that the patient-centered medical home is the best model, but it's the model we have right now. And this is really where there's a team approach. It's patient-centered. You have protocols in the background, which means that when you're in the office or in the exam room with a patient, you're not debating with them, and it's not a negotiation. This is what our protocol is, and this is what we can do for you, and you talk about that right up front. You have clear expectations. You monitor outcomes and do quality improvement projects if you're able to in the background, and hopefully your electronic health record enables you to actually have flow sheets and things which help with this. So you'd have, with this new model, a unified approach among providers. You have standardized protocol-assisted flow sheets. It's a little debatable what controlled substance agreements should be called, because they're really an informed consent. They really don't have much more than that, but it's really a way of sitting down with the patient saying, this is what I expect, and this is what I will provide for you. And just so that everybody's on the same page and you actually sign a form. You also, if you have teams of, say, physicians and mid-levels, there's definitely a place with chronic pain for that team approach, also with a nurse as well, because the physician provider does not need to see the patient all the time. You can actually designate people. It doesn't have to be a special person. You can designate somebody in the background to be assisting with this monitoring, so that it's not all on the shoulders of the physician or the primary provider of that patient. And then certainly there would be periodic reassessment and again, quality improvement. So this is our protocol in the residency, and so that you can read this a little bit better, I printed a couple slides out from that other lecture, and it's in your handout. And you know, the idea is that you assess the patient, looking for, you know, this is for people with chronic pain. You know, looking for, are they appropriate for, you know, different types of treatment? What is their risk based on their chronic medical issues? You're doing screenings like you would do between the 6 and 12 week period, and then you're treating them. And the next slide in this lecture here, I'll go through that. And then you're actually, you know, reassessing them. And part of that is to do some sort of validated screen for function and pain level. You're doing adherence monitoring, which, you know, can involve urine drug screening, pill counts, you know, maybe, you know, frequent visits, assessing for side effects, and constipation being the most common side effect. And then, you know, basically, hopefully you have a protocol as well for what do you do for the patients that fail. And I, as somebody who really is interested in community health, feel that it's not always the right thing just to fire those patients from our practice, because you're really putting them on somebody else then. But making sure that you wean them down, if you identify that they have an addiction issue, getting them into treatment. And then for our treatment overview, you know, this is actually from Dr. Berland, who is actually from the University of Michigan, I think. But anyway, we took this and kind of adapted it for our setting, but basically there's a whole sequence, and it's where you establish treatment goals right up front. You identify and treat local pain generators. Say that their chronic pain is coming from their knee and they could have a joint replacement, then certainly you want to offer that to them if needed. Promote healthy behaviors, like so. You don't want to provide opioids to somebody who's morbidly obese and is not interested in losing weight or exercising, because you're just going to exacerbate their problem, which may be, you know, sleep apnea. And that does go to the restore sleep. So you want to actually work with somebody to restore their sleep, because that may be the cause of their chronic pain if they're not sleeping well. And then start adjuvant pain medications, which would be like gabapentin or amitriptyline. Definitely treat comorbid psychiatric conditions, because you know, there are people that are appropriately treated with narcotics for chronic pain, and there is definitely a subgroup of that. And there's people over here that are definitely addicted, and then there's this middle group that are the chemical copers, they call them, which are people that are using their narcotic to deal with their daily stress. And you definitely want to screen out that person before you go to this step over here of initiating opioids. And I don't know, time-wise, I don't want to go past the time.
We have a few more minutes.
Okay, so this is actually, this slide here is a global view of, you know, one way to look at this within your community. I'm not going to, again, go into the QI project at the end, but what I really focus on and teaching about is, within the residency, is this clinical encounter. I have a partner that's really, you know, a specialist in addiction. He does those lectures. But basically, there has to be a balanced approach. So if you guys are interested in, you know, developing policies, you really should, as a community health center, engage your local community and health system. And the reason for that is that, in speaking with some other addiction specialists, if you decrease the amount of narcotics that you use in your office, there's going to be a spike of heroin abuse in the community, and it takes about 3 to 5 years to get that out of the community. So it's really important that it's a balanced approach to this. And you know, it starts with your practice, mission, and vision development. For example, if you are a free clinic, it probably is better not to push back narcotics at all, because you're going to be inundated with you know, patients that are trying to get that. You know, where I worked at Dayspring, we actually had new patient screening that we did, so we did not want people to be doctor shopping. And so we would tell them, number one, we would not prescribe control medications at the first visit. We told them when they called for the appointment that that was the case. And we also, we would not see people that were just coming because they were fired because of inappropriate prescription somewhere else. I would also advise, policies and protocols for chronic pain as a practice-wide, and then, again, this was the QI project I was going to talk to you about. Health system, I won't go into that, but local community, it's really important to have the providers on board that are outside of your practice as much as possible, and then you get, if possible, political and judicial involvement, maybe addiction services, community education. And then in the clinical encounter, the appropriate treatment of acute pain, certainly having the screens available that you need to screen the people for the appropriateness and doing the right documentation. In regards to the patient, again, the new patient education and screening, setting up expectations, self-management goal setting, which is very important, and could actually be a whole separate lecture on itself, so, which I won't go into, and then controlled substance agreements. And for the clinician, the most important thing is really compassionate care. I think that this is our way of really sharing the love of Christ with our patients. And again, these are our patients that are really hurting, and this is our modern day leprosy, I think. But at Dayspring where I worked, we actually had it so that providers did not, we requested that providers would not prescribe narcotics to control for chronic pain in the first 6 months of practice. And we did that to protect them, and all of them really appreciated it, and that is something that you could consider. And the reason is because so many providers would come and they would just be inundated with people trying them out, and we wanted to protect them from that. And then developing, policies and protocols and practice, primary and secondary prevention. So,